Me every week.
Every week? Well, no, you don't have to. You're welcome to meet with me whenever you feel you have a need to meet with me, or if I feel I have a need to meet with you. If there's certain things like you haven't passed a quiz or an exam or something of that nature, or if you've got concerns, or there's something you want to go over, tutoring, something of that nature, then absolutely, that's why I've got those calendar areas there. But what I'm not understanding why it isn't, some of them have, some haven't. I'm not sure. All right, guys. First things first. How did you do with your assignment?
You said, how do we do?
Yeah.
I think it was a lot of information that could have really gone into it. So we kind of had to like cue it down to what we really were trying to focus on, if that makes sense. There was much that could have been in that care plan. So much.
There's always so much more that you can do, for sure.
Yeah.
Please make sure, everybody, that you upload all of your pieces from the earlier stuff. I know some of you have. It's a concept map. It's the Word doc regarding the question, and also your skills are what I want to see first in the AM clinical work, and then let's see what you guys did. I don't know if you've uploaded it yet or not, so let me have a look. Okay. So no one's uploaded. You don't have to. You don't have to right this second. So why don't we do this? Let's look at this first of all as a little bit of a group. So this lady, 68, congestive heart failure, needs a lot of help with repositioning, getting up, doing anything. So she's at a high risk for skin breakdown, right? We know that right off the bat. And so how are you going to assess that? How are you going to assess her? If you want to share a screen and show me, you're in 3 different groups. Whichever group, you're welcome to show me what assessments you would do related to skin. How would you assess her skin?
Well, okay. We didn't necessarily do that. Let me call Caitlin. Where's she at?
I can tell you for Roswell she's doing by Mimi's doing.
Okay, go ahead.
We did look for skin changes such as skin dryness, pruritus wounds, rashes, or changes in skin pigmentation or color. To break it down, we palpitate the skin for moisture, temperature, turgor, and mobility. Check the skin integrity, see if it's intact. Evaluate the skin and mucous membranes in each part of the body for color, uniformity, thickness, symmetry, hygiene, and presence of lesions.
Okay. So that's how you would do your skin assessment piece.
Yes.
In answer to that question.
Oh, wait. What was that question?
It was number 1.
Yeah.
Let me look. Oh, Jesus.
What did you guys put?
Look, right? Let me look. Let me open this up real quick. I did put a lot. Jesus. Okay, it's taking forever. You can go ahead, Amber. Mine's taking forever to load.
We basically said the same thing as Evelyn. We were going to look for skin turgor. And then Rhonda said the Braden scale is a good scale to use. Obviously, check for lesions, any bleeding, any crusty dryness, all that. Do you want us to go through we made a PowerPoint. Do you want us to go
Sure.
Oh, geez.
like
There you go.
Oh God.
There you go.
Sorry, Mimi.
I would love to see a PowerPoint.
All right. I put it together for you guys.
You are rock.
Let me just trying to find her. I don't know, where is Rhonda? She's not on here. Here we go. All right, can you guys see that? Yeah.
I see it.
Yeah.
Okay. All right. So we did a patient history. So Phyllis is 68. She has a history of severe congestive heart failure, who is confined mostly to a bed or chair, and she requires assistance in changing positions and cannot bear much weight when transferring to the chair. And the patient is admitted for shortness of breath. And that's her. That's what we came up with. That's Miss Hefner, if you guys wanted to know. All right. So what assessments we are going to check for skin turgor and the Braden scale. I just put a little picture of checking for skin turgor. So there's all that. And then what complications can occur with chronic pressure ulcers? We said infection, sepsis, and cellulitis. And I saw this cute little picture of what to look for in sepsis. So shivering, fever, or just very cold. Asking for a heated blanket is a sign, but maybe they're probably just cold. I don't know. And extreme pain or general discomfort, pale or discolored skin, sleepy, difficult to arouse, and confused, feeling like they might die or like saying that, and then shortness of breath. And that's what she was admitted for. So there's a sign. And then cellulitis is a bacterial skin infection, and it's redness and warmth of the skin, just like swollen and inflamed, and that's to look for in pressure ulcers and stuff like that as well. And then the family notifies the nurse with concerns of a red area on Miss Hefner's left hip, saying that the redness doesn't disappear even after she's repositioned. And then these are just pressure sores that happen the most in patients, the most, I would say not the easiest, well, probably the easiest to get. Also the most, I forget the word here. You know what I mean though, just most common, that's what it is. This is just something else. Okay. What signs and symptoms of pressure ulcer on the left hip associated with stage 2 pressure ulcer may be presented? Skin is not intact. There's only partial thickness skin of the epidermis and dermis. It's just superficial, so it's not really going into anything crazy deep. And then bruising is not present. And in this picture over here, it just shows like stage 1 is just on the epidermis. Stage 2 is on the epidermis and dermis. Stage 3 goes a little bit into the fatty tissue. And then stage 4 goes deeper into the muscles and bones and ligaments, and then the unstageable is just, dead necrotic tissue. And then Miss Hefner becomes confused. Did you say something? No. Miss Hefner becomes confused, bladder and bowel incontinent, lack of appetite, fever of 101, left hip pressure ulcer grows with exudate, full thickness tissue loss, subcutaneous fat is visible, but the bone tissue and muscle is not exposed. And then wound is positive for MRSA on the left hip. And so what stage is pressure ulcer? We just put stage 3 because it is a full thickness tissue with a little bit of sub-Q fat visible, but not the bone or tissue or anything. And the Braden scale, we just put 1 for sensory, 1 for moisture, 2 for activity, because it says she was bed and chair rest, but I don't know. Mobility is 1, nutrition. It says she wasn't eating very well. She had a lack of appetite, and then friction. She put 1, so we put a 7. I know Mimi wanted to put a higher number. I know we were going back and forth about that. We'll talk about that later. But, yeah. And then discuss what steps would be taken to prevent transmission of infection when caring for a patient with a skin infection. We put contact precautions. With MRSA, I heard that you can only clean your hands with alcohol-based hand rub and soap and water. I don't know if that's correct, so don't come at me, but proper hand hygiene, you want to wear the correct size gloves just so they don't tear or anything to like fall in them if they're too big. And then appropriate PPE, gown and gloves, a mask. Sometimes, if you feel comfortable, or uncomfortable. And change your PPE when going to see other patients. Change the wound dressing. Observe for signs of infection, and then reposition patient every 2 hours, every 1 hour if you want. And then this is our care plan. So the subjective, we put pain, but that also could be objective. Okay, pain, shortness of breath, confusion. Objective, we put fever, redness on hip, and then bowel and bladder incontinence.
Okay.
For our first nursing diagnosis, we put impaired skin integrity. Our goals were patient will report any altered pain at site of tissue impairment, and by the end of shift, the patient will describe measures to protect and heal the tissue, including wound care. Our interventions, every 2 hours, inspect the patient for color changes, redness, swelling, and pain at infection site. Number 2, patient will allow staff to reposition her every 2 hours throughout the shift. And number 3, evaluate the patient use of support services like specialty mattresses or chair cushions. And the rationales for those is inspection can identify problems early, repositioning will promote blood circulation and skin integrity, and promote tissue perfusion. And then our second nursing diagnosis is risk for infection. The goals where the patient will remain free of infection as evidenced by normal vital signs and absence of signs and symptoms of infection. And the patients will demonstrate meticulous hand washing technique. We're going to check the patient's temperature every hour to watch elevated temperature. The nurse will wash hands and teach patient and show to wash hands before contact with, just teach them how to wash their hands correctly. Instances to wash your hands is before putting on your gloves and after taking them off, and before and after touching a patient, and before handling devices like a Foley catheter or putting in an IV. And then encourage intake of protein-rich and caloric-rich foods. Rationales is temperatures of up to 100.4 may indicate infection. Very high temperature occupied by sweating and chills may indicate septicemia. And the rationale for washing your hands is friction and running water effectively removes microorganisms from hands. And then the diet helps promote a strong immune system, or it just supports the immune system.
Yeah.
And then the outcome evaluation for impaired skin integrity, the patient was able to identify and understand any tissue impairment that could or possibly become infectious. Number 2, patient was healing to do diminishing redness in the wound area. Patient has healthy granulation tissue in pink in color and an indicator of healing and risk for infection. Patient was able to identify any abnormal vital signs for infection, and patient successfully demonstrated proper hand washing technique, and the patient was able to make good food choices with rich protein and calorie during meal times? Would that be like caloric, high
I
caloric?
with rich protein, and it would be high caloric
Yeah,
or high calorie.
high caloric.
Other things as well. Zinc, vitamin C. Obviously, I think it mentions that in the book about different types of nutrition as well that is utilized along with the protein. That was excellent question for you.
Mm-hmm.
And it talks about it in chapter 25 about albumin. Why would we bother measuring albumin? It's on page 451. We'll talk about it Thursday, but just to let you know, measuring albumin or measuring pre-albumin, serum pre-albumin levels, they're used to monitor nutrition. And you will see this a lot in the hospitals, and you may see it in the skilled nursing facilities too. But anyway, it talks about the serum pre-albumin level if it's less than 19.5, or the level is less than 3.5. That's normally an indicator that the patient isn't getting enough protein, okay? And we need protein, right, for that healing. So it's something just to bear in mind that you may see that in that nutritional consult if your dietitian leaves something there and you see about pre-albumin and albumin, and like, why would they? That's why. That's what they're looking at. They're looking at the protein factors there. What else are we looking at as well? And it talks about a lot of the food need to increase the diet. The other thing I want to bring to your attention on page 460, not 463, ignore me. Where was it that I wanted it? 469 talks about patient and family education regarding managing MRSA.
Sorry, I missed that.
You don't need to. But these are things that I'm just bringing out, you know. I like what you said about using the friction to get rid of the microorganisms, absolutely, and especially with things like C. diff, right? That's what we do for C. diff. Hand washing is huge for that. But MRSA, unfortunately, is one of those things. A lot of people are colonized for MRSA, and colonizing basically means that it's there, it's just not active. And I want to bring that out. As I say, we're going to go through all of this. If I can find it, here it is. Page 455. It talks about the fact that we're colonized with microorganisms. So on our skin, we have all sorts of microorganisms, right? We're walking around with all these things on our skin, but they're not, it's a sort of symbiotic relationship right now. It's not causing harm to us, and you know, they're just there. But the problem is, so it says here, colonization is the presence of one or more communities of organisms that attach to a wound surface. So they're there. It's non-pathogenic. You know, they're not really a problem right now. However, once it goes from colonization, these biofilms can lead to infection, and that's the problem. It says here, wound infection is a state of critical colonization with pathogenic organisms. So basically, it's no longer a controlled event. It becomes uncontrolled and leads to this infection that goes on. And a lot of the time, unfortunately, MRSA is one of those ones. Pseudomonas is another one. And so we do cultures, don't we? That's what we do. We culture these wounds. And that way we can figure out what antibiotic is going to be necessary to cover that infection. In the case of MRSA, a lot of the time we use vancomycin. That's one of the biggies that is used, IV vancomycin to help cover. There are other things that we can do, of course, lots of not just systemic things like IV vancomycin, but of course we can do wound therapy. And again, that has to be meticulous, right? It can't just be slapdash. It's got to be meticulous care in order to get the wound to start healing. Anyway, prevention of the spread of MRSA. It says a lot of things right here. Some of them, making sure we wash all uninfected skin area before the skin area, right? Things like that. We don't just get a washcloth and wash the whole thing. We wash everything else, and then the actual skin, the skin that is infected. Talks about making sure in the home that they understand to wash everything with super hot water, using a tablespoon of bleach as well in the surfaces, because MRSA is pretty virulent, right? Which is why you do need contact precautions whenever you're dealing with those patients. So there's a lot of pieces there about preventing the spread of MRSA within the home, but the same goes when we're in the hospital as well. These pieces, of course, are the same measures that we're going to use for that patient in the hospital. So good job. Excellent. Did you enjoy doing that?
Of course. Love my PowerPoint making.
I love them too. All right, who wants to go next?
We'll go, because guess what? I don't have all that. We don't have all that fancy stuff. But you know what? We're gonna go ahead and go just to get it out the way. Okay?
Okay.
We good with that, Kayla? You ready to go? Y'all gonna freeze over here on my computer. I don't know if y'all can see this, but here comes the case study is storming really bad. Oh my God. Can y'all see it? Can you see it?
Yes.
All right. So the case study in care of Miss Hefner, as it reads, Phyllis Hefner, a 68-year-old woman who has a history of severe congestive heart failure, who is confined mostly to the bed and to the chair. She requires assistance in changing positions or repositioning and cannot bear much weight when transferring to the chair. The patient admitted for shortness of breath to the hospital. So what assessments or relations to skin should the nurse make? So skin integrity due to her age and bed constraints is the risk. We looked for discoloration. We looked for elevated skin and lesions. We looked for redness. We looked for tears. We looked for cracks, scabs, blisters, skin breakdown due to immobility to self-position. We looked for her wet areas, dry areas, red areas. Skin breakdown due to non-weight bearing ability. We look for neurotic tissues. Because once you don't move and you lose circulation or whatever, your body can start to, tissues can start to die and we get numbness feeling or whatever. So we look for neurotic tissues. We look for black, purple, bluish skin tints. We looked for poor circulation, of course. And then she was a risk for swelling, weeping, and pitting edema. Because when you can't move and you can't circulate or whatever, you can't bear weight. She already has CHF. Then you're looking at a whole nother skin issue when your skin starts to expand, and then it can, like I said, weep or whatnot. So then risk of bed sores and pressure ulcers due to mobility inabilities and nutritional factors related to shortness of breath and congestive heart failure and pain. So this is a quick note that patients find it difficult to eat, chew, swallow when they are, and I said I spelled that wrong, when they are unable to breathe or are uncomfortable with pain. Okay. So question number 2, what complications can occur with chronic pressure ulcers? Pressure ulcers can lead to extremity loss, leads to permanent inability to walk, stand, lay in a certain position, or perform ADLs, which is activities of daily living. Pressure ulcers can weigh heavy on self-esteem and can cause disturbed body issues and problems that lead to failure to thrive, depression, and poor quality of life. How's that, little millennial? Pressure ulcers can also lead to other health issues such as diabetes, hypertension, pneumonia, MRSA, staph, and other bacterial infection, neurosis of the body tissues and organs. So it says here that a note was a family member noticed that the nurse notifies the nurse with concerns about the red areas on Miss Hefner's left hip, saying that the red does not disappear, and after she has been repositioned. The nurse completes a thorough skin assessment. The nurse notes that Ms. Hefner has a stage 2 pressure ulcer on the left hip. Did not take the doctor or a rocket scientist to figure that out. Why? Because what signs and symptoms of pressure ulcers are on the left hip associated with stage 2? Stage 2 pressure ulcers may appear as blisters with clear or yellow fluid on the inside. Due to what was assessed and found by the family and the nurse, the reddened area indicates some tissue damage that, if not rectified, can lead to further problems later. Signs could be consistent of worsening pain, increased red skin, fever or pus forming at the site, discoloration or darkened area, bluish purple and shining, hard and warm to touch skin. Signs that she has actually had, signs that she has actually had, one would be a scrape or abrasion appearance, blistered appearance, shallow craters in the skin, and can expand into deeper layers of the skin. Moving on, Ms. Hefner becomes confused and incontinent of bile and bladder and is not wanting to eat the medications that are provided. The nurse notices that Ms. Hefner has a fever of 101 and her hip pressure also has become larger and exudate. There is a full tissue loss of subcutaneous fat is visible, but no bone, tendon, or muscles are exposed. Some underlying and tunneling is noted. The wound is cultured and MRSA is growing from the left hip wound. So what stage is the pressure ulcer at now? It's at a stage 3.
Yep.
Using the Braden scale calculated from Ms. Hefner's score. So now let's talk about that as the millennial, my most favorite.
Let's talk about
Student wanted to go there. Let me go there with you real quick. The reason why we found an 11.
Whoa.
What? Hold on, let me break out my handy dandy. My lights are blinking over here. I hope the doggone computer don't go out. My handy dandy book, my med surg
Anne
book.
was saying that would be perfect timing, right? Anne was like,
Right. My med surg
and the
book
reason
told
is,
me-
boom. Shut up. Uh-oh, we lost her.
Hey, I win.
Oh no, she did freeze. Uh-oh.
I knew that.
Oh no, I spoke too soon.
You sure did.
You want to take up the slack,
Yes, I think I have it. Yeah.
Kaylin?
Hold
Poor
on.
Mimi. She's gonna
Let me
say,
pull it up.
it's all my fault, right? Oh goodness.
1 second. Let me pull it up.
What's funny is look how she's frozen with that
I
big
know.
grin on her face.
Right. She might hop back in on her phone.
Yeah. It is storming.
Oh, I don't have the updated one that we read.
Can you?
Ma'am, let me call.
Maybe she can get on the phone with us. Or hopefully we'll get her back. Oh, she was on a roll. Kaylin's frozen now. No, you're back.
Oh no, I'm not frozen.
I
But I'm calling Mimi on her phone. Oh, sorry if y'all can hear that.
Is she there?
Okay. Listen, I'm almost ready. I'm a lawyer now. I'm trying to get back into this. All right, here we go.
Thing you froze just at the minute where I said, this might freeze.
All right, but here we go.
Anyway.
Let's try to get through it. So the reason why the 11 on the Braden scale was because, according to the med surg book now, okay,
I'm
in
looking
regards
at
to
it.
the sensory perception, she was a number 3, which is slightly limited. Responds to verbal commands, because at the time she was, but could not always communicate discomfort or need to be turned. So that was why she was a number 3. Then we go down to a moisture. She, even though she got to be incontinent, there was a little bit of moisture there, not too much. Skin was often but not always moist, necessary to change linen at least once a shift. Okay, that fit. That was number 2. So if you add 3 and 2, we had 5 already. All right, so then we go down to activity, right? And that's where she was chair fast. The ability to walk severely limited or non-existent, cannot bear own weight, or must be helped into a chair or wheelchair. So now if you add 2 and 2 and 3, I mean, I'm already up to, you know what I'm saying? Let's keep going. Then we go to mobility. I put her at a number 1 because she's completely immobile to the fact that she needs somebody to help her with her body and getting extremely positioned with help. All right, I'm sorry, what number was I on? Let me keep going. So you got nutrition. She properly inadequate, so that means she didn't really eat no meals. She was down to half of her food. Protein intake includes 3 servings of meat and dairy product that she really wasn't eating, so she's at 2. All right, then on my last one was friction and shear. She's number 1. That's a problem. It required moderate to maximum help to move. Complete lifting without sliding against the sheets is impossible. Frequently it slides down into the bed or chair, requiring frequent repositioning with maximum assistance. I'm sorry, when I did the math on that, we had a good 1, 2, 1.
What did you have, Mimi?
3. I got 11.
You got 11. Okay. On the nutrition, I might put very poor. I don't know. But the bottom line is you're still at the same 11. You're at severe risk.
Right.
Yeah.
Okay, but like I said, that's where my 11 came from. I don't know where they get 7 and whatnot, but that's where my 11 came from. All right, I'm gonna keep moving. I'm gonna keep moving. No, the patient has scored 9, and I even put the Brayton scale on here for you. If the patient scores 9, she's a severe risk. If the patient is between 10 and 12, she's at a high risk. 13 to 14 is at a moderate risk, and 15 to 18 is considered a mild risk. So again, with my assessment here and the quick calculations of the Brayton scale, Miss Ma'am was at high risk. She's not completely contracted. She's not completely immobile. She can talk a little bit, which was why I did not put her at a severe risk. Let me keep moving. And she can bear some weight. All right, keep moving. Discuss what would be the steps taken to prevent transmission of infection when caring for a patient with skin infection. So Kaylin jumped in on this a lot. She really participated on this part extremely because I completely missed it. With that, she said proper hand hygiene. Oh, no. What happened? There you go. Is it still there? Y'all can see it. Okay. Yeah. Proper hand hygiene is always the first line of defense. In conjunction with proper hand hygiene, it is of the uttermost importance to ensure proper PPE is being worn and that the patient is being protected as much as possible from nosocomial infection. What's that mean, Amber? Hospital. All right. When cleaning the wound, it is important to use correct technique so that there is not any cross-contamination or spread of further infection, ensuring the sheets are changed immediately in the event that they become soiled or incontinent episodes, or dressing change is also important to reduce infection. Miss Hefner needs to be repositioned every 2 hours. There needs to be a cushion placed under her hip area so that it can reduce the pressure. Ensuring frequent changing is done during incontinent episodes will reduce infection and skin breakdown in other areas. The last thing she needs to do with the pressure ulcer is get it wet with unclean or unsterile fluids or particles. The dressing needs to be monitored closely. Ms. Hefner needs to meet the dietary department and with the physician to ensure she is intaking a proper nutrition that will help with wound healing process. Lastly, once her CHF is under control and the fluids from around her heart are decreased, mobility must begin. PT/OT should come and assess to see if there are non-weight bearing exercises or short steps with assistance that can be done in order to get her off her hip and get her to the ability needed to help with circulation. Defense rest their case.
I'm actually, it's so interesting that you said this. So I was actually thinking to myself, based on what I've just gone through with my father, I would actually use this in a court of law.
Thank you.
I mean, funny. I mean, seriously. So let me just get on my soapbox for a moment, if you don't mind.
Yes, ma'am.
I'm blown away at what I've been experiencing watching my poor father go downhill. Now, on Thursday, we're going to talk about skin as it pertains to different things. But let me just say this. This example, I switched around a little bit. And although it says a female, you know, my father is a male with congestive heart failure and all the rest of it. But what I look at is all of this process, and I look at the fact that we as nurses have a responsibility, an ethical responsibility to notice wounds, right? Noticing reddening of wounds, noticing anything that's going on with the skin and the changes and all of those types of things. So wouldn't you find it, wouldn't you find it crazy for a home care nurse to go out to a patient's home who is becoming immobile and not do a skin assessment, even though they're there to do wound care? They're there, and their logic is, we're there to do wound care on their legs. Huh? What? Is that normal to you? I mean, I've done home care. I've been a home care nurse. So do you think that's normal in any scenario to go and just do that?
It's not right, but I think that's what happens. That they just go out and do what the doctor ordered. Like if they want the pulse ox check, they just do exactly what is on that order. They don't do anything extra.
Right. Here's the thing. With nursing, we're not robots, right? Yet. We're not. I mean, you know, AI has come a long way, but we're not quite there yet. So I look at this and I'm like, we use our brains when we assess a patient, don't we? And all of what we just talked about with these presentations, looking at the person and going, oh my goodness, if I don't do something about this and assess them, this patient is going to die on me. And it's on me, really. So the reason I'm bringing this out, because when we see patients with pressure developing, we do have a responsibility to act on that as soon as possible, right? And get things in motion to prevent it from getting worse. Now, you're not always going to be able to prevent it from getting worse, but you can do your darndest on your shift to make sure that on your watch, it doesn't get worse, right? Yeah. So I just want to bring that point out. All right, I'll get off my soapbox. Who's next?
Oh,
I
we
was
got
waiting for that
done.
question.
Wow, look at that fancy
We
thing.
wasn't done. Come on, Kaylin, get it, girl. Go. Participate.
So, Mama, can you turn the TV down? We for our nursing diagnosis, we put impaired skin integrity related to immobility. The subjective was patient pain was a 9 out of 10. The patient stated that her hip was hurting, and patient complained of burning at the wound site. The objective was the exposed subcutaneous tissues and the change in the skin color with a fever of 101. Patient refused all meals and supplements and facial grimacing.
Can I just say, I would put the 9 out of 10 pain as an objective. Pain is a vital sign. So I think I have put if they're telling you the pain is 9 out of 10, that's more of an objective than a subjective. But I'm going to go with it. I'm just saying, I love it still anyway. But
yes, ma'am. So me and Kayla had and Kaylin had a kind of a debate with this because I felt like this care plan was missing something. So I put in parentheses that it was impaired skin integrity and risk of infection related to exposed subcutaneous tissue and discoloration as evidenced by a diagnosed stage 2 pressure ulcer.
Yes.
But Kaylin went ahead and she added the rest. And then so I'm gonna let her handle that. And then on statement 2, Kayla, if you can go ahead and read the nutritional imbalance part. Go ahead, boo.
The nutritional imbalance and risk for dehydration related to high temperature and refusal to eat, as evidenced by refusing meals, facial grimace, disorientation, and confusion. The patient will have an increased appetite and tolerate dietary. Oh, let me move this bar. How y'all move the bar again?
I got it.
Thank you. Supplements along with at least 2 meals daily to adequately refuel the body with nutrition from wound healing by 8/12/20. So 8/12/20 would be tomorrow.
She forgot to read the part where it says patient will receive stage 3 wound care and dressing changes every 24 to 48 hours to debride and irrigate infected wounds. All right, Kayla, go ahead. Nurse intervention.
The nurse interventions for the first statement. The patient will be repositioned Q2 out every 2 hours. The patient will receive PRN pain meds 30 minutes prior to dressing change and repositioning. A patient fever will be reduced to 98.5 with administration of Tylenol by 12, and the patient will rate a moderate 14 on the Braden scale within 72 to 96 hours. Because it can't happen overnight. Okay.
Right.
Yeah. Keep going.
You are super nurses.
And then in order to the patient will be repositioned every 2 hours in order to relieve pressure from site and prevent future ulcers and skin breakdown in other areas. The pain medicine will be given because the pain medicine will be administered in order to comfort and decrease pain prior to treatment and repositioning.
Yeah.
With the patient's Braden scale score, that's to promote healing and decrease further infection ulcers, basically. Statement two, huh?
Patient will consume 8 ounces.
Yeah. For the second, okay, let me finish. Let me do the outcomes. Let me stay on one little statement. Okay. Patient repositioning prevented reading to other areas of the body. So that goal was met. Patient was only able to report a 7 of 10 pain level, which gotten better from the 9 to the 10. The fever was reduced 98.3, so that goal was met. And the goal of moderate Braden scale is ongoing due to the wound healing process. Overall, goal partially was met. So, the nutritional imbalance. The patient will consume 8 ounces of dietary supplements. In examples like the Ensure at 6 a.m., 10 a.m., and 2 p.m. The nurse will encourage consumption of 100 mLs of fluid every 4 hours, and the nurse will perform range of motion with patient at the beginning and end of each shift. With the patient consuming the dietary supplements, that is for nutrition value is required for proper wound healing. Supplements are given to compensate for a nutrition imbalance in between meals. To prevent dehydration and maintain homeostasis fluid, proper electrolytes and fluid balance is required. Keeping the patient mobile is essential to prevent contractions, and mobility is necessary for wound healing. Patient was only able to tolerate 6 ounces of insert at each designated time. Patient consumed 80 mLs of fluid during meals, and patient was able to tolerate range of motion with no facial grimacing. So those goals were partially met as well.
Beautiful job.
Right.
And some of the goals are going to be ongoing because it's not a one day thing. It's not going to happen in one day.
Exactly. And it's a collaborative team, right? Like we talked about earlier. And so that's another piece of it as well. It's not just working in a vacuum, it has to be everybody doing the same thing round the clock. So hopefully they'll follow your lead. You know, with you being there you go. See?
Get that back to your
Uh-huh.
mama.
See?
Mom, come get your badge, man. Tripping.
There you go. Pin that on. Exactly. There you go. Exactly.
I had to speak
All
it.
right.
I had to speak it into existence.
Exactly. Let's see you guys follow that show.
Okay. Let me see if I can share it. All right. Can you guys see that?
Nope.
No.
Let's see. How about now?
Nope. The steak is calling me. I'm sorry. Did you go down here in the bar and where that little computer screen is? You hit that button.
Mm-hmm. Was
You
this
see
shared
the-
desktop?
Yeah.
Right.
Do you got it already? Do you have your stuff already opened on the bottom? If you got your stuff already open on the bottom of the screen, come on, Millennia, help. If you got your stuff already open on the bottom of the screen, then it's easier.
Hold on. Let me see. Wait, I might have found it.
I love you, Amber. You know that? No.
I love you, girl. That's my mom.
All right. All right, now can you guys see it?
We can see it.
Yeah, we can.
I don't know. Lost my brain here. Okay. Mine is not as good as Amber's might be, but hey.
I
it's
don't know.
something.
It looks pretty
I don't know.
fancy.
It does.
It looks fancy. All right. I renamed it.
Caleb. We still dropping right.
Technically, they tell us at work to rename it, so it's a pressure. They call it pressure injuries. And my little rattled nerves. All right, we did this case study of Miss Phyllis Hefner.
Just like my girl.
A 68-year-old woman with a history of severe congestive heart failure who was confined mostly to the bed or chair. She requires assistance in changing positions or in repositioning and cannot bear much weight when transferring to the chair. Savage. Chief complaints and medical history are shortness of breath, a pressure ulcer, left hip redness that does not disappear even when being repositioned, congestive heart failure, and minimal to no mobility. All right. Her current status and events are a fever of 101 Fahrenheit, left hip pressure ulcer that has become larger with exudate, confusion, incontinence of bowel and bladder, and not wanting to eat the meals that are being provided. The Braden scale is an evidence-based tool developed that predicts the risk for development of hospital or facility-acquired pressure ulcers/injuries. The Braden scale uses a score from less than or equal to 9 to as high as 23. The lower the number, the higher the risk for development of an acquired ulcer/injury. There are 6 categories within the Braden scale: sensory, perception, moisture, activity, mobility, nutrition, and friction and shearing.
You know, it's very interesting to me. This book might be an older version than the one you're looking at, FYI. Because in this one it says less than 11 is severe risk, so I'm just curious. So anyway, the point is.
There's an example of the Braden scale.
Beautiful.
And these are examples of what pressure ulcer looks like in the different stages. So stage 1, the skin is unbroken but inflamed. Stage 2, the skin is broken to the epidermis or dermis. Stage 3, ulcer extends to subcutaneous fat layers. Stage 4, ulcer extends to muscle or bone. And tunneling is extremely likely, undermining.
Yeah.
All right, nursing interventions would be reposition on the right side and a pillow under the left hip. Reposition every 2 hours. Keep the skin clean and dry. Change the chuck when wet or soiled. The chuck would be the pad. Provide a PureWick or a Foley catheter. Keep the sheets dry and wrinkle-free. Provide antibiotics, pain meds, NSAIDs to reduce the fever and infection. Provide adequate intake of protein and calories. Consult with PT, OT, and speech. Consult with the wound care team. Inspect and monitor site for skin impairment at least once per day. Clean and treat the wound according to the physician's orders, and consult with a home health care team. What stage is the pressure ulcer? It started at a stage 2, but is now a stage 3. And using the Braden scale, we calculated her as a severe risk, which was an 8.
Thank you. We have all different ones, but you all
act like you're 80. Go ahead. I'm just.
All right, the education. What assessment on admission in relationship to skin should the nurse make? Skin changes such as skin dryness, pertussis, wounds, rash, and change in the skin pigment or color. Palpitate the skin for moisture, temperature, turgor, and mobility. Skin integrity. Is the skin intact? Evaluate the skin and the mucous membranes in each part of the body for color, uniformity, thickness, symmetry, hygiene, and presence of lesions. What complications can occur with a chronic pressure ulcers? Infections such as sepsis, cellulitis, and osteomyelitis. And further breakdown of the site. Education would be what signs and symptoms of a pressure ulcer on the left hip associated with stage 2 pressure ulcer may be present. Stage 2 pressure ulcers are shallow with redness base. Oedipus and deeper tissue may not be visible. Granulation tissue, sloughing, and
eschar
are not present, intact, or partially ruptured blisters. Discuss what would be the steps taken to prevent transmission of infection when caring for the patient with a skin infection. The plan should include patient actions, education, staff action, education, and family actions and education. Wear and proper PPE, gown and gloves, hand hygiene, MRSA at-home prevention of transmission, wash hands, keep wounds covered, keep personal items personal, wash clothing and bedding in hot water, take food safety precautions, washing your hands before. All right, and that part I can't see. That part I'm gonna let Evelyn do because she wrote all that prettiness.
Good
Listen,
job.
you can tell.
She wrote it all. It's small on my eyes.
Did I write it all? Basically, I said the subjective was shortness of breath and history of CHF because that's my question to you. When it's a history of something, does that count as subjective because we don't really know if it's true or not?
Subjective things, CHF is a diagnosis.
Right.
So subjective is more about
if they say they're nauseous. You know?
Yeah, when someone comes into the office and they say what their chief complaint is,
Mm-hmm.
or hey, I feel nauseated, or hey, I feel short of breath, or gosh, I can't put much weight on my legs. Those are more subjective. Objective things are things that we quantify, meaning let me quantify that shortness of breath by noticing that her O2 sat is 92%.
Right.
Or let me quantify the fact that she can't bear much weight by the fact that when I evaluate, she has to use a walker to stand up.
Okay.
Or her strength is 3 out of 5 versus 5 out of 5 when I do, when I push on her legs and things like that.
So that's why I went even like the shortness of breath there, because it didn't say that we did pulse ox or anything like that kind of thing.
Right.
So her objective to me was, according to this, was her pressure ulcer or her left hip redness, because we could see that. We could see that she wasn't immobile.
Yep.
She had minimal mobility. We could see that.
Mm-hmm.
We could tell that she had the fever. We can tell by asking her questions that she had some confusion. We could tell that she was incontinent, and we could tell that she wasn't, and she wasn't eating either.
Right.
So those to me were objective stuff.
Okay.
So then we went with for risk for infection and risk for impaired skin mobility. The risk of infection was because of that she was immobile and she could have alterations in her skin integrity. And the risk for impaired skin was she had a couple of things going on. The inadequate nutrition, she had pressure over bony prominence. So that's kind of where I went with those. Nursing interventions would be we would observe and report any redness, warmth, or discharge, any a temperature on that. We would check it beginning of every shift. I would assess the temperature of her for infection, report anything that's over 100.5. And I would check her temperature. I think it's like 4 times a shift, isn't it? Like every 3 hours they do
Every
vitals.
4.
What?
Every 4. Q4.
Yeah. Every 4 hours. Okay.
Yeah.
All right. And I would encourage fluid intake throughout the shift for her, because she hasn't been eating. At least let's get some fluids in her. And you know that we want her to have 60 mLs to 120 mLs per hour. And then for the nursing intervention for the skin impaired, I would inspect and monitor the skin condition at least once a day, just like the other thing. And we would assess the nutritional status. We would initially refer her for a consultation, and then just assess her every single day, to see if she's eating, as she's eating, watch what she's eating. We would, of course, move her, reposition her every 2 hours. Rationales, I mean, they're basic. They're in the book: change in mental status, fever. I'm not going to go through all of them. Right. I felt like the outcome, we couldn't really give her an outcome yet, because she ended up with a MRSA infection. So she was going to need to be treated with antibiotics. And do what the doctor prescribed to do, and then we would assess her again at the end of the shift. I don't know if we can really tell if the antibiotics work. Maybe if after 12 hours she's feeling a little bit better, fever comes down. I don't know, but I said we'd have to reassess her. It was an ongoing thing. It couldn't happen that fast.
Okay.
And then as the pressure also went from a 2 to 3, we would continue the care as prescribed by the physician, and on every shift, just reassess her. So I can't give an outcome on her just yet either. I mean, the goal is to get that pressure ulcer solved, and then also get her MRSA under control and get rid of that. I mean, that's the obvious outcomes, but I don't think you can give her an outcome just yet.
Well, you guys did a great job. That's a lot of work today. Love it. I have one question. Do you think impaired skin would affect somebody's psychosocial?
Absolutely. I already, I spoke to that. And I said that, you know, the skin disturbances and appearances, whatever, people lose their self-confidence. They lose the ability to, you know, when people even who have rosacea or whatever don't like to wear short sleeve shirts, they don't like to, you know, be out without having something around their neck because and that's just a minor skin issue, or people with eczema who already have that scaly skin or whatever. So yeah, any type of skin impairment would be detrimental to somebody's, you know, to their self-esteem or to their visibility to society. So that messes with their brain because now they think they're ugly. So, or they think that something's wrong with them, or they're diseased or plagued or got lupus. What's it called in the Bible? Leprosy.
Leprosy.
So, yeah.
So yeah, it's important that we recognize that as well. So I just wanted to bring that piece out because I didn't hear any of that piece. And you know, I mean, there is the other thing I want to bring out as well is using the wound care nurse, of course, you know, as part of the collaborative practice, right? And I know that this is a little bit different, but it's important, especially when you've got these types of wounds, that you involve the team, that's what their focus is, and they know all the little nuances of the colloid treatments and the different types of treatments that can be used to help improve that wound. So that's just a couple of things that I just wanted to bring out. But you guys did a great job. Thank you, thank you, thank you, as always, for fully participating in all of this. And I really want these clinical pieces to supplement what we're going to talk about on Thursday. So that's why I sort of try and sort of bring it all together. So with that, what I want to just do, 5 minutes.
No problem. We can't submit the assignment. It's closed.
Oh, hang on. Oh, you know what it is? I'm so sorry. Give me. It said AM instead of PM. I thought it automatically. Hold on. I can organize that for you really, really quickly. That one. Come on, come on, come on. And then I just want to quickly go over the exam a little bit. So first of all make sure that you've got your phones or whatever you're going to use, so that you've got your laptop and then your phone so that I can see what you're doing. Secondly, calculators, whiteboard, whatever you need so that you can get this done well. Please read over the announcements to refresh your mind of what you need. There's 2 announcements that I put with PDFs that discuss the proctored process for you so that you understand that a little bit. It's basically going to be the same as what we're doing here right now. The difference is that you'll just have your phone or your iPad or whatever so that I can see your screens. It's really pretty much it,
So
right?
the test is over 11, 12, and 13.
Yes, I'm sorry. The chapters are 11, 12, and 13, just week 2. So with that,
and the ABGs inside the.
There are going to be a lot of ABGs.
Okay.
So I'm warning you.
So look inside the composition book for that.
I would suggest that you go. Remember, I said on module 2, I put some ABG practice worksheets there with the answers as well, and maybe just listen to the lecture that we did last week that I've posted. I've put the date of the lectures, you know, if you get a chance to do that. Or I think, doesn't your NCLEX book have ABG practice? But anyway, I would just really be aware of what metabolic acidosis is. If you need to do tic-tac-toe, if you need to do the Rome, remember, respiratory pH is opposite to the CO2, right? Metabolic is equal, meaning pH is going to be the same, meaning both go down or both go up, whereas in respiratory, the opposites occur. So that's what Rome is. Rome is respiratory opposite, metabolic equal. So you may want to use both of those pieces or Evelyn's that she sent to everybody. But try and really get this ABG piece in your head. Now, bear with me. I'm going to go through a couple of things for you because I really want you guys to do well. All right. Know your lab results to do with your electrolyte, potassium level, your sodium level, calcium level. Remember we went over those? Magnesium, know them. Remember I talked about angiotensin. Remember I talked about the renin-angiotensin system, and I went through that whole piece about angiotensin 1 converts to angiotensin 2. And what does an ACE inhibitor do? It
Lowers your blood
inhibits
pressure.
that action.
Oh, well, it lowers your blood pressure, but it inhibits your action.
It inhibits the action, right? Because angiotensin is what? A constrictor, right? It's a constrictor. So ACE inhibitor, the whole point is it causes some element of vasodilation. So I just want you to be aware of an angiotensin inhibitor. What do you think you might see in a therapeutic manner for that patient? If I've given them an ACE
Low
inhibitor.
blood pressure.
Thank you. Hopefully, yeah, right? All right. Remember I talked about insensible water loss. What is that? What is it?
It's like when it's coming from like your skin or sweat or something like that, right?
Right. What's hyponatremia?
Increased
Hyponatremia.
potassium.
What is
Low,
it?
Low potassium.
Natremia.
Oh,
low
potassium.
sodium count.
Sodium. What would be hypokalemia?
That's calcium.
That's potassium.
Thank you.
Wait. You said kalemia?
Hypokalemia. Not calcemia, cholemia. Hypokalemia.
Ka.
Yeah. All right. No foods. Like if I said a low sodium diet, what does that mean? If I said a low potassium diet, what does that mean? Bear those things in mind so that the patient knows what types of foods to eat, right? Or if the opposite, if you wanted to increase their potassium or increase their sodium, same thing goes. Know your potassium levels. What would be a dangerous level? If it is a dangerous level, what types of things do high potassium cause? Biggie there that I went over several times with you guys.
Is it like respiratory?
Cardiac.
Cardiac.
Yes, cardiac. All right, let me look at some other things here. Okay. Look at your pHs, your PaO2, your PCO2, and it will say PaCO2, AO2. Does that make sense? Still going to be your CO2 or your O2, but it has an A in there because it's the arterial, right? Because it's blood gas. Know your blood gases, know your levels. What's a normal pH?
7.35 to 7.45.
Yeah. Know them, know them, know them. Okay? Because there are a lot of ABGs here. And it's not necessarily, but I think you'll be fine, but you need to know your blood gas values. If you know your values, I think you'll do fine. But if I don't say it again, know your values. That's a big hint. Just saying. All right, there's at least about 6 questions to do with blood gases. Okay. PICC lines. Know care of a PICC line. Know what you're looking for with what types of complications can occur with these different lines, right? Infections, stuff like that. Remember I talked about intraosseous IV? Remember I mentioned that to you in the ER? You might see that. What does osseous mean?
In the bone.
Correct. So even if you don't know anything else, you know it's one of those that are going to stick it in the bone, right? Let's see. What else do I want to talk about? There are quite a few questions about IVs and IV therapy. Be aware of, hang on, there was a question I wanted to, there's a lot of questions regarding to IVs and making sure you're, you know, the infections and things of that nature, okay? Be aware of when you're delegating to somebody who is a UAP, what be delegated to do when it comes to looking after lines or not. One of the things I wanted to Hey Rhonda, I'm going to mute you. Are you muted? Good. Okay. There are several Select-All that apply. There are 5 dosage calc, and I explained to you already what type of dosage calc they're going to be. And there is one question, couple of questions that I don't know if I went over some scenarios. I think I told you about TPN, total parental nutrition. Did I talk to you about TPN? Basically, nutrition that goes in a bag, an IV bag, and the risks. Okay, good. And then the other thing I wanted to mention to you that I don't think I did is, if I can find it.
Did you say TPON?
No, TPN, total parental nutrition. And I know I discussed it a bit, but I think I did go over that a little bit, TPN and fat emulsion and stuff like that. Where the heck is it? I'm not sure if I went over intraperitoneal fluids, when somebody has to have fluids into their intraperitoneal. Did I don't know if I mentioned that to you, and I may not have done. Sometimes patients have fluids that they have into the peritoneum, that they go into the peritoneum and then they drain out again. So, as you can imagine, that might be a risk for what?
UTIs and
infection. Yeah. Now, you may see that type of thing very, very, very rarely with renal failure patients. Instead of having dialysis, they have what's called peritoneal dialysis. You know what I'm talking? So it's a big, huge bag of fluid, and they drain it into the peritoneal cavity, and osmosis occurs, pulls out the excess creatinine and BUN and all that sort of stuff, and then they take that fluid off. But as you can imagine, that's fairly risky for infection. So I wanted to just bring that out. It's not going to talk about peritoneal infection, peritoneal, but I thought there was one somewhere that talked about peritoneal, so I did want to bring that out to you. And why can I not find it? Well, I'll just see if I can find it for you. Bear with me. Maybe I took it out and changed it. Ah, okay. Yeah. So, I'm just letting you know, if you see when it's called intraperitoneal therapy, that's what I'm talking about. It's basically fluid that they put into the abdominal cavity and then they drain it out. But you can imagine that's sort of risky, right, for infection. So I'm giving you a big heads up on that, because that's not something that you're going to see that much, maybe rarely, but you know, it's something I just want you guys to be aware of. All right. Intraperitoneal. Does that make sense? But there are a lot of ABG questions, a lot. You will do fine if you learn your values. Or use your tic-tac-toe, or use Rome, whatever you have to do to get it in your head. All right. So let's do this, if you don't mind, on Thursday. Let's meet at 7:45, just in case there's any snags, you know, just so we can get you up and running. I'll get you out a little bit early, but I want to make sure, just in case there's anything we need to go over. But basically, have your laptops, have your phone, whiteboard. You may need a little calculator, whatever you need. And basically, you'll have 100 minutes to do your exam, and then we'll do our chapters, and that'll be it for Thursday. Okay. Any questions, concerns? Well, I'm sure there's concerns. ABG is always concerning.
Just, do you know off the top of your head, or am I just looking in the back of the book? Because when I have a problem with the computer. So when I look for in the clinical companion what chapters to go to, am I just looking in the back of the book where it says ABGs, and that suffice?
From what perspective? What do you mean?
So when I go on, like I told you, it was difficult for me to get onto the clinical companion from the modules. Mm-hmm. So in regards to, you said go to the clinical companion for the ABG. So am I just looking, I can just look up anything that you say by page number, right? I guess that's what I'm asking you.
I don't have that book, so it's hard for me to tell. You can show, what does it show you? Now,
it says acid-base imbalances. I mean, so I guess that's it.
If you want to use that, you know, I don't mind what you use to help you study ABGs on your own, along with the stuff that I've put up from week 2. If you want to use that, some people like Picmonics. Some people have that mind where they're like, okay, metabolic acidosis, they have a picture in their brain of what that looks like from Picmonics. You know, so whatever works for you is the way to go. If you want to, let me see what else. As I say, I did put some ABG questions up for you. Whatever works. If you want to use that, Use that.
Yeah, I found it. It's good. It got the lab values in it. It's good.
Great. I think in your med surg book as well, it has all the lab values in it.
Yeah, we still got papers from Professor White, but yeah.
Yeah, I was going to say, in chapter 12, it's got all of the the lab values in here. Let me just, bear with me. I would strongly suggest you go over it. Page 188. It's got the ranges for the acid-base balances. I'm sorry, and look at if you want it. Don't look at venous, just arterial, right? If you need it there. I think you got it, you guys. Okay. I will see you, let's say 7:45 on Thursday. All right, everybody? Okay.
So there's no class tomorrow?
Not tomorrow. It's every other week. Yep. So next Wednesday we'll have class. Okay? So you got more time. All right, guys. See you Thursday morning, 7:45. And I hope you have a good rest of the evening. Hope your father's okay, Amber.
Yeah, his blood pressure or his blood sugar is at
I can't touch it with mine.
671.
Is he a type 1 or type 2?
Type 1.
He's type 1. My husband is too.
But his doctor never told him to prick his finger and check for his blood sugar until like literally probably like a couple days ago.
Excuse me. He's a type 1 diabetic?
Yeah.
Well, how long has he been a type 1 for?
He was pre-diabetic probably about a couple months ago.
So he sounds like he's a type 2.
Oh.
Type 1 is, and actually it says type 1 is more of an autoimmune. They're on insulin straight away. Type 2s are the ones that pre-diabetic, then develop more diabetes, need to be on metformin and one thing or another.
Okay, yeah.
But it sounds like something has happened, you know, that has caused his blood sugar to go crazy. Huh. Wow. Interesting. Is he gone to the hospital or is he back?
He's still in the ER.
Yeah. Yeah, they'll admit him. They'll have to admit him and get that blood sugar sorted for sure. Wow.
He had pancreatitis a couple years ago. So he was in the hospital for like 6 months or so.
Okay.
A long time. He had like 3 different surgeries. And he had a heart surgery. It was just a bad year that year, a couple years ago.
Wow.
And now he has like 20 plus DVTs in his legs. Like his health is just going.
Yeah. Oh, I'm so sorry.
Yeah.
Oh, that's a lot.
Mm-hmm. Like when they were doing the ultrasound on his legs, the nurse was like, "Oh my gosh, I've never seen this many." But yeah.
Wow. Yeah. Yeah, he'll need fluids, that's for sure. Fluids and an insulin drip. Get that blood sugar down.
Nurse Millennial got it.
Oh.
Is he at Baptist South?
Yeah.
Yeah. They do a good job. Dr. Salomon.
He always says he has a one of those when you go to a store, you know how you have one of like their cards. He always says he has a Baptist South card because he goes there so often. Yeah. It's called a frequent flyer card is what he calls it.
Frequent flyer.
Yeah.
Yeah. Yeah. Yeah, my husband is a type 1. So as I say, when we talk about diabetes, I'll see if I can get him to model his little subcutaneous pumps for you. I hope he does okay. I'm sure now he's getting some care. He will.
Yeah.
Say some prayers for you.
Thanks.
All right, guys. It's been a pleasure as always. I'll see you morning, and we will rock this exam. All right?
I pray so. Yes, ma'am.
Bye.
Bye.
Take care. Bye-bye.
Bye. Amber, reply.